A very good evening to you. Welcome to our program iMed. And last week on iMed, we were talking about pediatric eye problems, and we do have a lot more to highlight on this topic. So we have with us Dr. Niranjala Vidanage once again in the studios. She's a senior registrar in pediatric ophthalmology at the Lady Ridgeway Hospital for Children. Doctor, a very good evening to you, and thank you for joining us this week as well. And last week we did touch upon certain common eye problems and also the important eye problems which we see in newborns and also in preschool children. So we were talking about squint eyes. So let's touch upon how we could manage this and also the seriousity of this and how important it is to consult a doctor.
Yeah. Once we diagnose patients having squints, as I discussed in the last program, we have to assess the vision of the patients, and we have to look for the refractive errors. That means the patient may be having some errors, the patient may need glasses. So then we have to assess the fundus and exclude any other pathologies inside the eye, as well as we have to check the eye movements. Sometimes the paralytic squints may be there. That means the nerve supplying from the brain, nerves are coming inside to the eye, to the supplying the muscles. They may be got paralyzed. In that case, we have to refer the patient to the neurologist as well. And we have to do the orthoptic assessment to further analyze the squint with the, for example, for the binocular vision, and to measure the how much the squint is as a baseline investigation. So then if the management wise, if the patient is having refractive error as well, we have to give the minus glasses.
So there are various types of squints as well.
Yes.
And once it's detected, you can prescribe. So is this reversible as well?
Yes. Now I am talking regarding the only conservative management. As I said earlier, the glasses, and then sometimes the patient is having a convergence deficiency. So we are prescribing convergence exercises as well. And sometimes if the patients then after assessing the patient's vision, if the vision is low, then we are starting the occlusion therapy as well. Occlusion therapy means we are covering the normal eye and allow the patient to see from the squinting eye. So the normal signal may go to the inside the brain, and the normal visual pathway is developing, and the patient may gain his vision. So these conservative management, sometimes the usually, actually not sometimes, the squints is settling with time, but we are doing investigation and routine follow up up to the about 6 to 7 years age, and if they are feeling that even with the normal conservative measures, the patient may not settling with the squint may not settle with time, we have to go for surgery. And I must emphasize some point in this, because some entity called infantile esotrophia, that means the esotrophia, that convergent squint present at the birth, and it is we are calling cross fixation, because the patient looking at when he want to look at this side, he is moving the head this way, and the other side this way. In those patients may be having walking difficulties.
Right.
So in those children in infantile esotrophia, we can't wait just like a patient having refractive errors. So we have to go for early surgery even before 1 year of age. The other children with refractive errors and conservative management, we are actually observing with some time and go for surgery. And surgery wise also, I must briefly explain regarding the what is we are going during surgery. What we are doing is we are the muscles are supplying the orbital cavity. So we are cutting and adjusting the muscles the way the eyeball can be move straight. The focusing of the eyeball is in a straight way without divergent or invergent. And sometimes the parents' concern is sometimes they are telling that doctor, my baby is having squint on the left eye, but you did surgery for both eyes. So it is maybe sometimes, even though the squint is manifesting in that eye, we are sometimes doing surgery for the both eyes. So it is not a mistaken for the doctor. It is the way we are handling the both muscles, because the combined effect is the ultimate result and ultimate gain of the surgery. So we are reducing and we are adjusting the muscles accordingly. Ultimately the eye becomes straight.
Exactly, and that's with regards to squints, and also it's very important for parents out there.
And one more thing to highlight, that if we surgically corrected the squint and once the patient is having normal eye alignment, still the squinting is the eye affected eye may be having low vision. So in that case we have to still continue the occlusion therapy until the patient is having the more or less similar vision to the other eye. So that means doing surgery is not the end of the story. You have to
have follow-ups
until with the occlusion therapy. And one point is usually the kids are resisting for the occlusion, so it is very important to the mothers to be patient with the baby and allow them to adapt for the occlusion slowly and continue that. Then if the patient is coming in late stage, in that stage we can't get their vision back because the normal development stage is over. In that case we are doing only cosmetical surgery just for the alignment, but the vision can't gain.
Right, so that's what happens when you don't go to a doctor in early stages. When you see a difference in the eye, this is, I think, a good advice for the parents out there. If you notice something, it's important for you to consult an eye surgeon and speak to the person and get to know more details about the condition. And doctor, you also did mention about glaucoma during the previous program, that this is also a condition we see in children. But we've heard about adults getting glaucoma. Long-term diabetes can lead to it, and a lot of other conditions and genetic conditions as well, if I'm not mistaken. So how can children get this, and is it common?
I can't say it is common, but it is a very important topic to be discussed, because of the kids once a kid develop glaucoma, it is we have to investigate thoroughly, and we have to intervene very urgently. And not like adults, the management of the glaucoma we can't do only with eye drops. We have to go for surgery. So first I'll discuss regarding few common causes for glaucoma. Mostly you can see this picture. This is the normal pathway in the anterior part of the eye. There's the eyeball is filling with aqueous, something called aqueous humor in anterior part, and vitreous humor in the posterior part. So we are dealing with the anterior part now. There's something called aqueous humor. It is it is generated from the ciliary body from here, just anterior to the it is very nearby to the crystalline lens, and once it's produced, it's coming to the towards the pupil, and to the pupil it's coming and draining to the trabecular meshwork. So if something is obstructed in normal pathway, I can't say exactly what is the cause. Maybe developmental problem during early stage of development, and maybe some obstruction in this trabecular meshwork. The children are developing congenital glaucoma. And the other entity is juvenile glaucoma. It is not the developmental problem. It may be due to long-term steroid therapy, as I mentioned you regarding the allergic conjunctivitis, or any other system problems. The lot of pediatricians giving prednisolone or steroids for the patients. And the other sometimes the patient undergo any eye surgery to any other problem, just like congenital cataract. And sometimes after trauma. So these are the most important causes for juvenile glaucoma. So the most important thing to diagnose this condition early as possible, because this leads to irreversible blindness. And once the optic nerve fibers, why the patient is developing blindness is, you can see in this picture, there are this optic nerve. This is a fundal this is the most posterior part, photograph of most posterior part of your retina. So this the optic nerve is the nerve connecting brain into the posterior part of the globe. So usually it has a lot of optic nerve fibers. With the increment of intraocular pressure, it will gradually be destructed, and that lead to irreversible blindness. So that is why we have to intervene early stage, and these are the common manifestation of the glaucoma. These sometimes patient present with hazy cornea. You can see in the left picture hazy cornea. That is due to the high intraocular pressure, the transparency of the cornea can't be maintained, and the protrusion of the eye. If the patient is having only glaucoma in the one eye, the parents say come in with the doctor, my daughter's or son's one eye is larger than the other eye, and with time it is protruding out like that. And the other most common thing is tearing as well as photophobia. That means difficulty in seeing the light. So once we diagnose how we diagnose actually glaucoma is we have to measure the intraocular pressure. Sometimes the intraocular pressure may be normal, not like adults, and you have to look at the as I told you earlier, look at the fundus to get the view of the optic nerve head. And we have to measure the corneal diameter, because the corneal once we enlarge the corneal diameter getting higher and higher, and sometimes we have to do gonioscopy to see the trabecular mesh, the angle that draining the aqueous humor as well. So after diagnosing, usually we are starting with the medications, but as I told you earlier, it is very difficult to manage the pediatric glaucoma with drugs. Usually we have to go for surgery early as possible. And even with the surgery, the story is not ending up. You have to follow up the patient for a long time with the intraocular pressure, with the length of the eyeball as well as the cupping, that posterior part of the eyeball, that optic nerve head. And usually, not sometimes, the surgery may be repeated because of the eye structures are varied than adults.
And the condition as well.
Yes, condition as well.
And doctor, we are left with 10 minutes for the program, and we have a few other conditions to be highlighted on the show as well, which is common among newborns.
Yes.
And important concerns as well. So you did speak about retinopathy of prematurity. Shall we elaborate this? What is retinopathy and why do we see this in children?
Yeah, it is a condition usually occurred during in the children who born prematurely. That means about 32 weeks of gestation. Usually the babies are born at 40 weeks of gestation. So this is the condition. Actually, this is a neovascular condition. The normal vasculature occurred from the optic nerve head to the periphery of the retina. In these children, usually it starts at 16 weeks of gestation and it's end up about 40 weeks of gestation. But in these children, they are born prematurely, so there's no time to complete the vascularization. So after birth, the normal vasculature is not spreading toward the periphery. So what happens is that their abnormal vessels are forming. Because of that, the complications occur, and ultimately the retina get detached from the eyeball and ultimately ending up in blindness. So the risk factors for the development of ROP is not only the gestational age, and the birth weight must be less than 1.5 or nearly that category, and the patients who received ventilator support, oxygen therapy, and treatment for systemic infections and blood transfusion and poor weight gains are also having risk of developing retinopathy of prematurity. So I think you can see this picture. There is the upper this picture. You can see there's normal vasculature is there, and this is the avascular area, and this is the area, the vascular junction is the area that development of ROP is there. And then we are the screening. That's why the screening program is very important. There are 5 stations which we are conducting screening for the ROP, retinopathy of prematurity. The Lady Ridgeway Hospital for Children, and the Sidma Bandaranaga Memorial Hospital, and Teaching Hospital Karapitiya, and Teaching Hospital Batiklo, and Teaching Hospital Jaffna. So the patient actually not just after birth, about 4 to 6 weeks of age, the pediatrician will refer to those centers, and screening is going on in a very successful manner. Because I'm saying like that because earlier in blind schools, the children are most of children, there are a lot of children are there. The blindness, the cause is retinopathy of prematurity. But nowadays, with the successfulness of this program as well as good neonatal care, not only us, the care of the baby during that PBO care and the neonatal care must be very good for not to develop ROP and not to progress ROP. Because of that 2 reasons.
Do we see any symptoms?
No. Because the babies are too small, they can't actually they can't even focus. So just we can grab things because with the screening, but we are putting some dietary drops to the pupils, and we are seeing posterior part of the retina. Then we are grab things, and we have to treat very early, vigorously, as well as in a appropriate way to reduce the blindness from this condition. So what we are doing is we are using laser therapy, as well as we are using injections into the eye, and sometimes if the patient is present in late stage and already the detachment of the retina is occurred, we may go to surgery as well. So with this the management options, we can actually preserve the eye, the vision of the eye.
And doctor, you also
இந்நிகழ்ச்சிக்கு பிரதான அனுசரணை
வெட்டிங் ரிங் ஜெம் அண்ட் ஜுவல்லரி பிரைவேட் லிமிடெட், குருநாகல், நுகேகுடை, அனுராதபுரம், பம்பலப்பிட்டி.
கேட்ச் மசாலா சும்மா பட்டாலே போதுமே.
mentioned about something called the congenital cataract.
Yes.
What is this?
It is a opacification of the crystalline lens, but the difference between this and adults is usually adults is due to the aging process, but congenital cataract usually there may be underlying pathologies there. In usual bilateral cases, we have to investigate the baby further why the patient is developing cataract. For example, maybe he is having metabolic causes, maybe he is having intrauterine infection like rubella, and sometimes he is having some systemic causes like trisomy 21 and Down syndrome like that. So we have to refer the patient to pediatrician, and the common presentation of the congenital cataract is white reflex. You can see the this picture
Image on screen.
Image. There's a white reflex is there. You can see inside the just behind pupil. You can see white reflex. So just after the white reflex, the cataract is not only the reason for white reflex, but in here this is the cause is the cataract. So don't misunderstand. Every patient with white reflex is of course is congenital cataract. So once we identify this, and if the patient vision is affected with the cataract, we have to remove the lens as soon as possible, maybe during first month of age, to prevent the that eye getting lazy or amblyopia. So if the patient is less than 2 years of age, we are just removing the cataract and managing the baby with contact lenses or glasses. And once the baby reaches the age of 2 years, we can implant the intraocular lens. You can see the picture. We are putting the intraocular lenses inside inside the eye. Then still the patients need to wear glasses to see the near vision, and sometimes we have to do the occlusion therapy to normalize the vision up to the normal.
So this is with regards to congenital cataract. And doctor, let's also touch on retinoblastoma as well.
Yes. Retinoblastoma is although it's a rare condition, it's a very important cancerous condition to detect early, because if we detect it in late stage, definitely we have to remove the eye, and sometimes it may spread to the brain as well. So it is vision threatening as well as life threatening. Retinoblastoma actually arising inside the retina, and it's grow towards inside the orbital cavity, that inside the eyeball. Then the most commonest presentation is again white reflex, and sometimes squint also can be maybe the first manifestation. So and in this here I must highlight regarding the familial tendency of the retinoblastoma. Retinoblastoma is due to the mutation in the retinoblastoma gene. Sometimes it's come with the inherited way from the parents, and so if the parents is having retinoblastoma, family member having retinoblastoma, it is very important to inform the condition to the VOG, and we can detect the condition regarding intrauterine life this scan as well, or just after birth within 1 month we are advising patient to mothers to come back with the baby to identify the early stage. So if we identify in the early stage, we can preserve the eyeball as well as it may spread from the optic nerve inside the brain. So we can prevent that. So the treatment options are we have to give chemotherapy just like other cancers at the Maharagama Apeksha Hospital. Then we are giving laser therapy as well as cryotherapy and some injections inside the eye. Then if we intervene properly, we can actually, not the vision actually, sometimes we can preserve vision, we can preserve the eye globe. If the patient is coming in the late stage, we can't preserve the eye, then we can go for enucleation. That means completely removing the eyeball, but still not to worry regarding the cosmetic appearance, because we have in prosthetic eyes. So we can apply that and patient may have in near normal appearance of the eye, even though the vision is not there. And the other important thing is even though this is removed, the patient can develop other tumors in later in life. Therefore, they have to follow up long termly.
Because they are prone to it, isn't it?
Prone to it, yes.
So these are matters which get ignored as well most often, and then that could lead to blindness and also life-threatening, as you did mention, doctor. So we've come towards the final few minutes of the program, and I think you also did want to touch upon complications, eye complications associated with juvenile idiopathic arthritis as well, and how you manage it. So let's quickly touch upon this topic as well, doctor, before we wind up.
Yeah. Usually these patients are following a rheumatology clinic, but the point I must highlight is these patients are prone to develop eye complications. We are telling that uveitis, but the most pathetic situation in here is usually you can see this picture. Usually not the patient with arthritis. Usually if the patient is developed uveitis, the patient is coming with tearing and redness. But in here, the patient is developing uveitis, but there's no red dye. That is, we are telling that uveitis in white dye. So no one knows that patient developed that condition until the complications occur and ultimately leading to blindness. So it is very important to the parents also, they are responsible to come to the baby to the eye clinic as well as rheumatology clinic, and rheumatologist also must refer to the patients to the other clinics, eye clinics. Then we can examine the patients and identify the uveitis and treat vigorously without going to the complications and ultimately ending up with blindness. So it is very important to not like adults with rheumatic, that most common condition is rheumatoid arthritis, not like that. The babies are having usually having ocular complications, which must be treated vigorously with long-term medications and drops to prevent the complications.
So that's with regards to eye complications which can be associated with idiopathic arthritis.
Yes.
And you did mention a lot about the importance of getting the children checked as soon as possible.
Yes.
So any final message to the parents out there, doctor, before we wind up the show?
Actually, as the final stage of this program, I must briefly summarize my the 8 conditions. Mainly the screens, don't miss that. Again, always come to the doctor early, soon as possible, and because sometimes the underlying pathology may be cancer formation inside the globe. And regarding occlusion therapy, because the usually the children don't like to do the occlusion therapy, so but always encourage them to do that long termly to preserve their vision. And that regarding that retinoblastoma also, I must tell that if the family member is having retinoblastoma, always inform the VOG, and then we can detect it early as possible. And regarding that first topic of recommended duct obstruction also, the massaging technique must be done properly.
Thank you very much, doctor, for enlightening us on the different conditions and concerns as well. I'm sure there's plenty, but everything could be prevented and cured if it's detected early. So thank you very much, doctor, for enlightening us.
Thank you.
And we've been talking to Dr. Niranjala Vidanage, Senior Registrar in Pediatric Ophthalmology at the Lady Ridgeway Hospital for Children. So with that, we conclude this week's edition of iMed. Thank you very much for tuning in. Have yourself a pleasant night.